you. So I started doing radiofrequency ablation in New York in 2019, and then for various reasons, not work-related, more family-related, we moved back to Australia in 2021. So I was lucky. It was very easy for me to bring the technology and the procedural knowledge that I had and to start it up in Australia. And I remember that was the time of COVID in Australia, and there was pretty strict immigration laws, and I was sitting in the hotel in quarantine and having to call up the various companies and hospitals and try to get started with radiofrequency almost as soon as I hit the ground. And I was very lucky. The company STARmed was very supportive of me starting in Australia, and one of the hospitals, Cabrini Health, was very supportive of me starting doing the procedures at that hospital. But I think one of the biggest challenges was just trying to explain that there is a lot of evidence behind these procedures, that this wasn't just some newfangled technique that I suddenly wanted to introduce to the country just because I'd arrived in the country, but instead that there was decades of experience in other countries, and that I myself had experience doing the technique as well. And I think that took a fair bit of convincing initially, but I was lucky to have had that experience because it made it easier for me to start doing the procedures in Australia. So that was initially, and I guess acceptance by surgical, endocrinology, just general medical communities, and with regards to this procedure, which was brand new to the country, was another major hurdle to overcome. And it's one that we're still, I'm still overcoming, but I think there is general acceptance now that this is a viable alternative for a subset of patients with thyroid nodules. Patient selection, in my mind, is one of the key factors in achieving good success with radiofrequency. It's something that I speak about a lot, and I think being able to select the right patients and the right disease type for these sort of procedures is really something that we should all focus on. And the reason that that's important is that patients often come with expectations about what radiofrequency can achieve, about what the outcomes should be, and often those expectations may not be relevant to their type of disease or their particular situation. And so counselling them and making sure that they understand what radiofrequency can do for them with regards to their specific disease type is absolutely essential. In addition, making sure they understand that although it is minimally invasive, there are risks associated with it. And I think the general impression is that it is far safer than surgery. But I like to counsel patients that with a very good thyroid surgeon, our risks of injury or complications are extremely low as well. And so I generally counsel that I think the risks of the procedure are actually pretty similar to the risks with a good thyroid surgeon of undergoing thyroid surgery. Ultimately, it comes down to weighing up the pros and cons of something more invasive like surgery and something less invasive like radiofrequency, and determining what is best for that individual patient. Hormone preservation with radiofrequency is key. The possibility of regrowth is a negative, and that definitely is better addressed with surgery. And so weighing up this balance scale, provided a patient is eligible for both radiofrequency and surgery, is really the most important thing with selecting patients and making sure that they are suitable for the procedure. So I like to think of success indicators as patient success and then practitioner success, and they're interrelated but perhaps slightly different. For the patient, it's resolution of their symptoms, which are usually compressional symptoms. So it may be visibility of a nodule, fullness in their neck, difficulty swallowing, very occasionally change in voice, but that's much less common. And having resolution of those symptoms, or for an autonomously functioning nodule, having return to normal thyroid function, they're the kind of markers of success for the patient. from the practitioner, from my point of view, a marker of success is achieving more than a 70% volume reduction in the nodule. 50% has been classically used in the literature as a marker of success. I use 70% because most nodules that I ablate will get to that 70% level. There's been some larger volume nodules that will only get between 50 to 70%, and although that's successful and often patients have no symptoms, often those patients will need to go on to have another procedure afterwards. So I think from my viewpoint, it's achieving a good volume reduction, having a nodule that looks well ablated, that doesn't regrow, and having a patient that's happy with the outcome, that has no symptoms. And from the patient's perspective, it is obviously all of those things, but more importantly, that their symptoms have gone away and they can live with their disease rather than worrying about their disease. Complications during radiofrequency are a very real thing, and there are numerous published literature reports of complications. Most of us who've done many radiofrequency cases have had complications ourselves. Probably the most common one is minor hematoma or minor bleeding at the site of puncture, and that can luckily usually be managed with direct compression and doesn't actually require aborting the procedure or having to stop the procedure for a long time, but often you do need to pause and put pressure on that. I think one of the more feared complications is injury to one of the laryngeal nerves, and that may be the recurrent laryngeal nerve at the back of the thyroid in what we call the danger zone, or a medially placed vagus nerve or sympathetic ganglion, which is not a laryngeal nerve but another important nervous structure. One of the protocols that I've brought in and kind of spoken fairly widely on now is using what I call continuous auditory voice analysis, CAVA, for maintaining vocal function during ablation. And this is where I actively have patients count in a very monotonal voice, 1, 2, 3, as I'm ablating in those danger zones. And the reason we do that is to listen to their voice, because when that nerve is heated or injured, that vocal nerve, you almost invariably hear changes in the patient's voice. And this is different to during surgery, where delayed recognition of voice change is possible due to the effects of intubation, due to the effects of compensation by the other cord over weeks after surgery. When it happens in real time with ablation, you can hear that. So I think that's one of the protocols that I've brought in to try and minimize risk to the vocal nerves. But the other important factors that I've already sort of mentioned are making sure you select the right patients, knowing the anatomy on that patient before you start, knowing if there's a medially placed vagus nerve, knowing if the sympathetic ganglion might be adjacent to the lateral border of the nodule, knowing where your recurrent laryngeal nerves and superior laryngeal nerve may run, and being able to identify these structures and use techniques such as hydrodissection, low power, choice of electrode type, all of these things to minimize risk to these structures. I think it's important for patients to be very aware of the possible complications that can occur before the procedure, so that if something does happen, they are aware that that was a risk, and then you manage it accordingly. And there are, a lot of good resources for patients online, but also I provide obviously resources if there is any complications. Luckily, we haven't had many, as to, what the likely outcomes are, what the likely sequelae of that complication is. And luckily, most complications, at least most of the mild to moderate complications, tend to resolve with time, particularly voice effects. And so patients can generally be reassured that many of these things are short-acting or can be resolved conservatively without requiring any intervention more than perhaps antibiotics, steroid treatment. So I think I'm, most proud of having got this up and running in a new country and having brought this procedure to Australia. It's been an interesting journey over the past 3 years. It's still a very patient-driven journey where patients find out about the fact that I am doing ablation in Australia. They've been watching it worldwide for many years and they're excited that it's finally in Australia. And I think being able to give them the option of ablation is a very satisfying thing. I think being able to select the right patients, as I've mentioned, is key. And so there's a huge amount of work that goes into counselling patients, checking we've ticked all the boxes to make sure their disease is actually eligible for ablation, that their nodules are benign, or if they're malignant, that they're very small malignancies. All of these things are important when we're trying to kind of make sure a patient is eligible. So I guess being able to give patients an extra option in their care is probably one of the things I'm most proud of. What I would like to do is set up some, which I have done one training course in Australia, but I want to get more training courses going. There are other practitioners that are now starting up with radiofrequency in Australia, which is very exciting, and I'm proctoring or have proctored some of those and will in the future, and just trying to make sure that as this becomes more widespread in Australia, as we did in America, that it's done safely and that hopefully there are minimal complications, and that comes down to having the right proceduralist do the procedure with the right skill set and the right experience, and also to choosing the right patients who are eligible for this procedure.